Assalamu alaikum. I'm Dr. Nouman Khan, Registrar Cardiology, PIMS. Uh, Before going to my case, I would like to thank you, PMA and Dr. Akhtar Bandesha, President PMA, for inviting us. So I'm direct, without wasting my time. So we are going to our case. That is. It is a case of 64-year-old male who is a known case of type 2 diabetes and also a known case of ischemic heart disease. He was diagnosed as triple vessel coronary artery disease 8 years back, for which he was advised cabbage, but he refused at that time. Since then, he was on optimal medical therapy with the second line anti-angiogenic treatment, but still he was symptomatic, and he was coping with that. He presented this time with chest pain that was started at rest 5 years back. It was radiating to his left arm and jaws. Furthermore, there was no associated exacerbating or relieving factors. Furthermore, his vital signs were BP of 140/80, all were within normal limits, and his cardiovascular examination was also unremarkable. ECG shows normal sinus rhythm with diffuse ST changes, ST depressions, and AVR was up. Drop T was positive. That's being done by kit methods. Risk stratification done for this patient, and his grade score was 113, and his TIMS score was 5. So he was initially managed in cardiac emergency and then was shifted to CCU before proceeding to coronary angiography. So basically, he underwent coronary angiography, and angiography results were just like before. It was the native TVCAT, and there was a heavy calcification. But the patient was given again, his centric score was above 33, and he was advised cabbage. But they asked for time so that they can decide and make consensus. The surgeon was ready, but they still refused and opt for intervention. So we are going to proceed to our first slide. So here we can appreciate clearly the heavy calcification in the. So this time we were directly stenting the left system LED. So we engaged the left system via a VU 3.5 guide. Here is another RO caudal view of the same patient. First, we crossed the lesions in the LED via Renato wire, and then we exchanged it with the microcatheter. The rota wire is in place right now. I just put one slide of the rota. Initially, there were 5-6 runs to break the initial, 2 to 3 runs for initial breakdown of the cape, and then 2 to 3 runs for the mid lesions. These were the results after rota ablation. After that, we done pre-dilatation before stent deployment with compliant balloon of 2.5 into 15. This is after the pre-dilatation results. Stent Science Expedition 30 into 48.